My name is Ralph Weber, and I'm going to talk to you a little bit about some products and services of medicine. And we'll get to that in just a few minutes. Also about MediBid, which is a company I started. I'll give you a little bit of my background. I'm originally Canadian. I left Canada in 2005 after my wife waited 2.5 years for foot surgery, for orthopedic surgery. In Canada, as you may or may not know, it's single-payer system. And Canada and North Korea are the only two countries where it's a true single payer, which means you cannot pay a physician for care. You simply have to wait or leave the country. So that's how I ended up in the U.S. Since '05, even though I've been working in the U.S. since before that. I grew up mostly in Thailand, lived in Kathmandu, Nepal for a couple of years in Germany, Canada, and the U.S. So I've had a lot of different backgrounds in terms of seeing a lot of things. And also I've seen medicine, not only medicine, but healthcare in these different countries and continents. And I've seen that change. The healthcare system that we have right now in the U.S. is the same healthcare system we had 5 years ago, and it's the same that we'll have in 5 years. You know, it's run by third-party payers. The product is one of the things that I want to talk about, because let me ask a question. How many of you had a parent who was a physician or an uncle? Anybody? Okay. That's usually the case, about a third. In the days that probably when your parents first started practicing, you know, back 30, 40 years ago, medicine was different. The product, the service, was medical treatment. Okay, it was medical care. That was the product. That was the service. Today, the product is healthcare. And what is healthcare? When politicians talk about healthcare reform, what are they talking about? Well, healthcare is simply a financial instrument. It's health insurance, okay? It's a Blue Cross plan, it's Medicare coverage, so it's a financial instrument. And because the financial instrument is the product, medical treatment becomes the byproduct, okay? Imagine if we bought a car the same way. We'd shop for a car loan, and then we'd go to a Toyota dealer and we'd say, okay, I've got this car loan. What kind of car does this entitle me to? And they'd say, well, you can get a Yaris with a 5-year maintenance package. And then you'd go to a Chevy dealer and they'd say, well, what am I entitled to with this? And they would tell you. So what I'm saying is that a health care is a private entitlement system that whether we purchase an individual policy from an insurance company or whether we have it through work or through one of the government programs, it is an entitlement program. In the third-party payer model, you have a separation between the physician and the patient. You have a three-way relationship with the payer being right here and the patient being here and the physician being here. Okay? You don't have a direct contract. You might think that it's a small point, but it's actually a huge point. It's actually a huge separation because the natural incentive in a third-party payer system, whether it's a AAA membership or whether it's a healthcare plan or whatever kind of third-party payer system you have, the incentive is for the patient who is paying all or a portion of their premium, either through taxes or a premium or whatever. They want to get as much out of it as they can. Okay? They've paid into the system or into their premium. The physician also is paid by this carrier, so they want to get as much out of the system that they can. Now, don't get me wrong. People that become physicians have the patient at the front of their list. I understand that totally. I'm just saying natural incentives, okay? Moral hazards which exist, okay? People want to get paid fairly for fair work. What happens with the third-party payer system, and I'll give you a brief overview, and this is with commercial payers, private insurance company, Blue Cross, United, Aetna, et cetera. What they generally tend to do is they will have the hospital and the physician bill what's called a charge master price, which is usually 4 to 6 times the Medicare rate, 400 to 600 times the Medicare rate. They receive this bill and then they reprice it from 600% of Medicare to 300% of Medicare. And then they'll produce an EOB, which is an explanation of benefits, and they'll send it to the patient. And they'll say, you know, $6,000 was billed, $3,000 is not allowable. So $3,000, the other $3,000 is the allowable amount. Pay your deductible, copay, coinsurance based on that $3,000. Then, however, once they have that money, what they actually pay the physician and or facility is usually, actually almost always less than that 300%. Okay, on average it's about 125%. So there's this other big gap. Insurance companies that are driving healthcare have no incentive to keep the cost down. Okay? As a matter of fact, there's a disincentive. They want to drive the cost up. With the ACA, there is a mandated medical loss ratio, which says that an insurance company must spend 80% of what it takes in premium on medical care for individuals and small groups, 85% on large groups. So what that means is if they get your premium, let's say you paid annually in advance. If you paid January 1, by December 31, they have to have spent 85% of your money on medical care. So that means by mid-February, they have to have spent all of it. Okay, so they only have your money for about 13 months. If you buy life insurance, car insurance, disability insurance, house insurance, critical illness insurance, that company has your money for 30, 40, 50 years. And they can make, even if they're making 3% interest a year, they're making it over decades and decades and decades, and it multiplies your money. Okay? That's real insurance. It insures unsystematic risk. Healthcare is not real insurance because they have 13 months. It's money in, money out. The only way that the insurance companies can make money is on margin. So if you go for an MRI as opposed to an X-ray, they make more money. So there's no incentive to keep costs down. If they don't spend your money, they have to give it back, so they'd rather spend it because they can take a piece out of that as a patient access fee, which they consider a medical cost. That's money that they don't have to refund. Okay, so that is one of the fundamental problems with the third-party payer system. I was telling Dr. Sutton and Matt here earlier, I have a client who is a small physician's office in Florida. They have two physicians, family practitioners, one full-time physician's assistant, one part-time. Total clinic revenue is just under $3 million. Less than 13% goes to the doctors. Less than 13% out of every dollar that's paid for medical care goes to the doctors. They have 36 full-time staff, including the doctors and PAs, so 32 others supporting these doctors. So you have a bunch of bureaucrats, okay? A bunch of administrative people. And don't get me wrong, we need administrative people, but that's 16 to 1. I mean, that's a really high ratio. That's kind of an extreme. They went bankrupt. They declared Chapter 7 bankruptcy because of the administrative burden. Now, where does it come from? The administrative burden comes, remember that gap I told you between 300 and 125? The doctor's office, not the physician himself or herself, but the doctor's staff has to bill the insurance company, and then they'll say, well, that wasn't a level 4 visit, that was a level 3 visit, so therefore we're only paying so much. Or that person wasn't covered or wasn't entitled to this or whatever. They will try to pay the doctor's office less, okay? And the doctor's office will try to say, no, this patient was seen and this is what was paid, or this is the service that was delivered, so therefore this is what we want. It goes back and forth. It usually takes 120 days for the physician's office to get their money. That's why they need so many administrators. But then you're paying the administrators, not the doctor. So if we have an 85% medical loss ratio, that means if you pay $1 to an insurance company, you're going to get 85 cents worth of medical care. You pay 85 cents to this doctor's office, and 13% goes to the doctor. So what's 13% of 85? It's about a dime, right, more or less, okay? So 10 cents out of every dollar goes to the doctor. And herein lies the problem. It's because the product is health care, not medical treatment. And it creates enormous amounts of waste. Now, the people that drive healthcare, whether it's the insurance companies or the government, are saying, well, we're going to make it more efficient. We're going to give you some electronic medical records. Now all you have to do is sit the patient down and you touch screen, press some buttons, and then send it to us and we'll analyze it. Where's that going to end? I mean, in my opinion, there already is a huge database, and they call it evidence-based medicine, whereby, based on the evidence of a million patients that had these indicators, this therapy, this modality was the most effective. At some point in time, will we simply have a call center where they're taking calls and say, list the symptoms, and they use the same device? I mean, is that where it's going? We don't know. I mean, I think that's the direction they're trying to do it. So one of the reasons that I created MediBid is because it changes the product. It changes the product back to medical care, medical treatment. Let me explain MediBid really, really simply. We've been described as the Travelocity of healthcare, the Priceline of healthcare. Now, my first question is, did Travelocity bring down the cost of travel or push it up? Hotels.com. I mean, even Match.com, okay? We're used to using electronic means to shop, to research, okay? So MediBid is an online portal where physicians will register, and they will talk about where they went to medical school, where they did their residency, their internship, their fellowships, what they're boarded in, how they practice, the languages they speak, their gender, their age, and a little bit about themselves and how many procedures they do a year. That way, when the patient goes to make a medical request, and we generally have three kinds of patients. One of them is an uninsured person that's paying for it for themselves. Another one is somebody with a high deductible health insurance plan where they want to save some money. And the other one is through an employer-sponsored plan that uses MediBid instead of the PPO network. So the patient goes on, makes a medical request. I need a knee replacement, I need a colonoscopy, whatever. They will put in how far they want to travel, if at all, and then they will review the bids that are submitted by doctors. They get to see the profile of the physician. They get to see the quality indicators. They get to see the charges. They have total transparency. There have been some physicians that have criticized that. They've said, well, in medicine you have to pay more to get better care. However, number one, since 90% doesn't even go to the doctor, I mean, you're paying more to feed bureaucrats and administrators. Number two, because physicians are reimbursed in the third-party payer system by a CPT code, of which there's 14,193, soon going to ICD-10 where there's 140,000 billing codes. So because physicians are billed by a code, there's nothing that says a better doctor will be paid a higher reimbursement than a less experienced doctor. Hospitals bill differently. They often bill by 15-minute increments, as do anesthesiologists. Therefore, if you have a good surgeon that does the job in half an hour versus an inexperienced surgeon who takes an hour and a half, not to talk about the extra blood that is needed and all that other stuff. You have all these extra nurses, all the assistants, and all of that hospital billing. The hospital bills 3 times as much for time. So often, when you pay more in medicine, you get less. And that's because the product is healthcare. And with any financial instrument, such as the subprime mortgages, such as the Lehman Brothers, Goldman Sachs of the world, with a financial instrument, you can make a lot of money on financial instruments. People make, look at Warren Buffett. People make a lot of money, a lot more money on a financial instrument than you can on a service that you produce. Whether you're a CPA, an attorney, a physician, when you produce a service, you're limited to the number of hours in a day and your expertise and some market forces. But when you're selling a financial instrument, it's unlimited. So much of the waste that we have, the financial waste in medicine, is driven by the bureaucratic third-party payer system. Dr. Sutton.
Can you speak to the metrics you guys report for quality and how you vet that?
Okay. Sure, absolutely. It is self-reporting. The physician has to put in their license number. We check to make sure they're licensed in good standing, not suspended, etc. If they are, then they can put in their stuff. And we don't check, are you really boarded, in orthopedics or whatever. However, once the patient selects the doctor that they wish to perform the procedure, they're emailed the license number and so on, and we give them research tools. We said, here, before you go, you might want to go ahead and check this out. Okay? Here's where you can look up physicians. Now, there are some third-party systems that rate doctors. There's a whole bunch of them, some good, some bad. But for us to be a rating system would totally change the paradigm, totally change the model. So we've chosen at this time not to go there. We let people do their own research. I'll give you a good example. We had a patient recently. This was featured on the Today Show. This patient was, he was in the construction industry in California, back when construction was booming, prior to 06. He needed a total hip replacement. He was told it was a 6 to 12 month recovery time. And he knew that he couldn't be out of work in Southern California for 6 to 12 months. He'd go bankrupt. So he put it off, he put it off, he put it off. And then the housing collapsed. He lost his insurance. He couldn't get it anymore. He went back to work and he got new insurance and he waited until it wasn't a pre-existing condition anymore. He said, okay, now I'm covered again. Still, I'm going to be out 6 months. Anyway, the pain was so bad that he decided, I'm going to get this surgery. I need to get this. The pain is too much. His leg was 1.5 inches lower, shorter on one side than the other. So he finally decided, I'm going to get the surgery. He booked it. It was scheduled for a Tuesday, and the Friday just before that, the insurance company called him and said, guess what? We're not going to cover this. This procedure isn't going to cover it. So he said, well, what are you talking about? The hospital said, well, listen, if you want to pay cash, we'll give you a 30% discount if you pay in advance. And he said, well, how much would that be? And they said, well, the surgery is $100,000, but we'll give it to you for $70,000 if you pay cash. Now, he could not afford $70,000, and he could not afford 6 to 12 months off of work. So he found MediBid. And he tells this story on the Today Show. He made a request for bid. The first day, he got a reply from India for $7,000, all in. He decided he didn't want to go to India. So the next day, he got one from Glendale, California for $14,000. He got a couple from Houston for $17,000. Eventually, he got one from San Antonio for $21,000. And the doctor that bid $21,000, the orthopedic surgeon, said, I'm probably not going to be the lowest price out there. So if you're price shopping, I'm not your guy. But I do something very different. I use a minimally invasive procedure where I don't cut through the muscle. It's a 4-inch incision, and you will walk out of the hospital the next day without a cane. So Perry, which was the name of the patient, accepted this, and he's allowed me to use his name because he's posted a testimonial about it. He accepted the bid, and he says, I like it, I'll do it. He did a lot of research on his own. Everybody here, is there anybody that doesn't have a smartphone in here? Anybody? We're used to doing that research now. He did a lot of research. And what he found was, wow, Blue Cross didn't tell me about this procedure. I never heard about this. He did a lot. He decided to take it. $21,000 versus $70,000. He went in, and literally the next day he walked out without, I know that hospital, always say we have to wheel you out, but he walked out on his own steam. Within 2 weeks, he was back to work climbing ladders with 2x4s on his shoulder, okay? So he called me up and he says, I want to thank you for saving my business. And I said, what are you talking about? And he told me the whole story. And I said, well, look, it was the surgeon. It was the surgeon. He says, no, you changed the paradigm. With the insurance system, I could have never had this done. It would have cost me, just in my copays, my deductible alone, it would have cost me almost $21,000. And of course, once they said it's not covered, it would have cost me $70,000. I couldn't afford it. I couldn't afford the time off. So by setting up this system whereby I can find these kinds of things, you've changed the system. Our system has become so bureaucratic, okay? Even before the ACA, it was very bureaucratic. And the ACA has not helped. It's made it more so. There's more, paperwork. There's more box to check, okay? There's more administration. A while ago, I think the ratio of doctor to administrator in private practice was 7-1. I think it's now up to about 12-1, 11 or 12. Okay, the one clinic I told you about earlier, that was ridiculous. That was 16-1, which is why they went bankrupt. But it's not unusual to see, 8, 9, 10, 11, 12 administrators per physician. And then the product is different. Okay, you all entered medical school because you want to heal, because you want to practice the art of healing, not the art of administrating. Matt asked me another question, which is a very good one. Is there a benefit to a physician having a business degree? Absolutely. Absolutely. Now, there are some physicians that aren't cut out for that, and that's okay too. There's nothing wrong with that. But I think it's a great plus. I have seen so many of my clients who are physicians embezzled by the practice administrator. Because a good physician is not necessarily a good business person. They will hire an administrator and they see all this money. And they see, because of the opacity and the pricing and repricing and all this stuff, they see an opportunity to skim. It doesn't happen all the time, but it happens too much. It really does happen too much. So yes, there absolutely is, a need. So, again, getting back to what we've done, by changing the product back to medical care, it puts the patient in charge. It reconnects the doctor and patient so that they have a relationship, okay? The patient will see what their insurance is going to cover, okay? But the driving force is the medical care, the medical treatment. That becomes the product. You can't control a byproduct that is a widget of a financial system, of a financial instrument. It's very, very hard. It becomes a commodity. And you could argue that an MRI can be commoditized, okay? An MRI, what controls do you have? Is it Tesla 1.5, 1.0, 3.0? The reading of the imaging is important, but that kind of a thing, it's kind of a little bit easier to commoditize than what an internist does, or a surgeon, or any other thing. The goal of the third-party payer is the financial instrument. So they want to commoditize everything. They want to steer you towards certain things where they can bill, like at 600, reprice it to 300, but then pay less. Okay, that's what they want to do. Changing it back, yes, Dr. Sutton.
So what's your revenue model? Do providers pay a subscription fee to be listed on your site?
Mm-hmm. Yes.
Have you had any traction with large corporations that are traditionally friendly to domestic medical tours in places like
Yes.
Clinic and Mayo Clinic?
Yes. The physician pays an annual subscription. They do not pay a percent of each patient, just an annual prescription, okay? Subscription fee. The patient also pays. Now, if they are an individual, they can pay each time they make a request. And if they're a company, as you were just saying, and we have one that just signed up a month ago with over 100,000 users, okay? And they pay a per employee per month fee just for the access, for their members to go online and get it. We're talking to a group that has 173,000 employees, total of 361,000 users, okay? This is another company that could come online. They see the validity. I'll give you one really good example. In the state of Minnesota, due to the medical board rulings, a colonoscopy must be done under general anesthesia. Now, I don't have to tell you about the additional risks to general anesthesia versus sedation. I'm sure you all know that. In Wisconsin, it can be done under sedation in a doctor's office. So obviously the price difference is ridiculous. Now, is it better quality when you're under general anesthesia? You know more about that than I do. I don't think so. I don't think so. It's a lot more cost. If you had a traditional health plan which covered 80% in network and 50% out of network, here's how this would look. Let me just make up some numbers. Let's say it's $2,500 in network in Minnesota because you need general anesthesia. It's probably going to be a lot more than that, but let's just assume that. And $1,200 in Wisconsin. 80% covered by the payer means 20% covered by the patient. 20% of $2,500 is $500. If they go out of network to where it's $1,200, they're paying 50% of $1,200, which is $600. There's no incentive for the patient to do that. The plan would save a lot of money, but the third-party payer system disincentivizes savings in this manner. So we end up steering people to more expensive treatment, which is not necessarily higher quality. When I look at a large company, when I look at their claims month by month, I see 4 kinds of medical claims. Number 1 is catastrophic. Heart attack, cancer, car accident. Totally unavoidable. Companies, when they're trying to reduce their healthcare costs, they might increase the deductible. That's not going to affect catastrophic claims at all. They happen when they happen. Second kind are chronic. Okay? Hypertension, diabetes, smoking, obesity. You can increase the deductible. It's really not going to affect those medical claims a whole lot either. They're going to go through their annual cliff deductible in 2 or 3 months. And I'll come back to that term, annual cliff deductible. The third kind are sort of the frivolous claims. They usually happen October, November, and December of every year when people have used up their annual deductible. They say, hey, deductible's used up, what do we need done? Has that ever happened to anybody? Where you've used up your deductible on your health plan, let's get something done. It happens all the time. Yeah, so you know what I'm talking about. The fourth kind are the early stage claims. Like my mole is changing colors, I've got chest pains, I've got headaches. Usually when this happens to somebody in October and they haven't satisfied their deductible yet, they say, well, I'm going to wait until January when I have a new deductible year. There's no sense satisfying the deductible with 2 months left. I've wasted the money. So they wait. And then what happens in 3 months? It can become a stage 3 illness, right? So the annual cliff deductible changes behavior to that extent. Most of us operate on a monthly budget. We pay our premiums monthly, we pay our car insurance, our rent, our mortgage monthly, but we have an annual deductible. They don't work. They increase the cost. So doing things like a monthly deductible on a health plan instead of annual, just a simple thing like that, decreases cost by about 21% because it puts behaviors in line with needs rather than with finances. Okay, so there are a lot of things, a lot of improvements that we're making through MediBid to change the product back to medical care. And that is really the fundamental issue. Now I'd like to just take a few questions. Matt, I know, is it okay to go on a few minutes?
Yeah.
Okay.
Are you guys okay with that since we started a little late? Or let's make it brief.
Okay. Any questions?
What has been your relationship with Oklahoma Surgery Center?
Oh, great question. Keith Smith is one of he's a good friend of mine. He's a member of AAPS. We have a great relationship with him. The Oklahoma Surgery Center was the first surgery center that started posting their prices online, just posting them online. They get a lot of patients from MediBid. They get a lot of patients through MediBid because they have fair prices for good quality work. Keith Smith is a pioneer. not only is he a brilliant anesthesiologist, he is a great business person. I don't know if he has an MBA, but if he doesn't, he should. Because he understands how the business and the art of medicine blend. So the third-party payers don't like what he's doing, but it's all about transparency. Good question. Thank you. Any other questions?
What I was asking about earlier with the MBA was because they're really expensive degrees to get, is what I understand. An MBA can cost you $150,000
Wow.
for 2 years. That's more than medical school.
Mhm.
So what I was wondering is, does that translate in terms of just profitability? Do you think that degree makes up for itself in the long run?
Oh, absolutely.
Positions?
No question. No question at all in my mind. By the way, you can get one online from Russia for $15,000. No, I'm kidding. No, it's a good question. As I mentioned earlier, understanding some of these, dynamics, about 90% of what's paid for medical care. I mean, look, everybody's going to have overhead. When you go to your CPA to have your taxes done, they've got overhead too. He's got to rent an office. He's got to have a receptionist. So there's always going to be overhead, but 90% is ridiculous. It really is. Also, all of the, the pricing and repricing, tracking that, okay? Marketing your practice. Now, when we invest, whether it's through a 401k or whatever, they talk about diversification. In any business, you also need diversification. Diversification of income. If you have a single payer that's paying 80% of your income, if they cancel your contract, you're out of business tomorrow. So you should keep each payer, to a certain level. And if a payer isn't performing, if they're not paying promptly and paying what you bill or a large percentage of what you bill, fire that payer and then dedicate your time. The Association of American Physicians and Surgeons is very large on private practice and cash practice. Okay? With a cash practice, you have a direct relationship between physician and the patient. They pay at the time of care. They pay a fair price. They may or may not get reimbursement from insurance. However, there's not all of the administrative burden that's required to build these insurance companies. So, Matt, to answer your question, having an MBA, even for 150 grand, I mean, yeah, that's going to pay for itself really quick.
Okay, when you were mentioning like with MediBid, it's all procedures based. How do you transition that to office based? Because if someone has a chronic illness, they're going to see a specialist.
Okay.
So they're going to have most of the time go to a teaching hospital, so they're going to pay that copay fee.
Right.
How are you basically going to cut out the insurance? Like I have Blue Cross Blue Shield.
Right.
So whenever I'm like, oh, pain,
Right.
I'm going to run to the doctor
Uh-huh.
and
Yeah.
I'm going to pay the little copay, which
Right.
has gone up every year.
Right.
What I'm saying is people who certain doctors, they're not surgeons, they're not going to be doing procedures.
Right.
How can they get themselves on MediBid?
Okay, good question. We have a lot of concierge practices where they charge a monthly membership, for sort of unlimited care. We have a lot of those. We have a lot of family practitioners, internal medicine. Usually what happens is when it's procedure-based, the knee replacement or the colonoscopy or whatever is the procedure. You get the procedure and that's it. What you're talking about is you're really shopping for a doctor. You want your family doctor. And they might just bid on one visit, but then you keep that doctor and you keep that relationship. You use MediBid one time for one visit. You don't use it every single time to go back to that doctor because then you have that relationship. Okay, does that answer your question?
Yes.
Okay, we had a question up, yes.
Oh, I guess this is sort of a comment question going back to the MBA thing, is that, I mean, being someone who's already, doing 4 years, an additional 4 years of school, like, that also is sort of detracting me from, wanting to pursue an MBA.
Right.
I'm kind of wondering, is there some sort of, like, in between, like, are there some medical practice basics that could be sort of incorporated into the curriculum that, every medical doctor can use and
Good point. It's too bad Dr. Sutton just left. Yeah.
He's in charge of the business and medicine, the business and
Oh, the
leadership track.
distinction in business.
Yeah, Yeah.
Yeah,
that's-
I know that that's like another sort of thing that's out there, but.
Right.
I feel like
I-
there are things that are important enough that could.
Yeah,
everyone.
I mean, I think your point is, if you're raising kids, it would be great to be a psychologist, but are you going to get a PhD in psychologist to raise kids? Like, is an MBA kind of overkill? And I get your point. To Matt's point, the people with that are oriented that way, it's not overkill. But to people that are saying, hey, look, I understand the need for some basic business sense. I totally get it. But, a couple extra years, 150 grand, 2 years less income, where do I draw the line? That's a great point. So maybe what medical schools need to do is just integrate a little bit, maybe like a quarter of an MBA program, whereby you get at least some of the basics. In a typical medical school, how much do you learn about business? Really, how much? Zero, exactly. Yeah. I mean, this hour is probably more than you're going to learn the rest of the time. But it's important. It's important, And if you have a good faculty advisor, such as Dr. Sutton, that's willing to reach out to people, such as myself and other business leaders to come in and talk, then that's a great start. It's not going to replace an MBA, but it's going to get some of the basics. I think that integration could be done. Yeah, thank you. Any other questions? No?
All right, thank you very much, Ralph.
Okay, thanks, Matt.